Good afternoon, everyone, and thank you for attending the Multi-Modality Conference, continuation of the Multi-Modality Imaging Conference. And today I will be talking with you guys about the use of CMR for assessing the right ventricle and right-sided heart valves. And give me a second while I start sharing my screen. Okay, so today, like I said, we'll be discussing the use of CMR for assessing the right ventricle and right-sided heart valves. And this is kind of segueing off of the great talk Dr. Sharif Naga gave last week. And the thing about the right ventricle is that first off, here's my disclosures. Nothing to disclose. The thing we need to first answer, though, is I know Dr. Naga covered things in great detail, but what exactly does the right ventricle do? And I know most of us are familiar with its function and anatomy, but this is just a brief overview for the non-cardiologist, non-physician members of the audience. Just a bit of history. Sir William Harvey back in the day discussed the right ventricle for the sake of picking up blood from the body and transmitting for the lungs, but not for nourishing them. But the basic idea behind the right ventricle is it receives blood from the systemic circulation, be it through the IVC, through the SVC, or the coronary sinus, and sends it to pulmonary artery, where obviously gas exchange occurs, and then the blood returns through the pulmonary veins back to left atrium, where the left ventricle then takes over and does things. In the absence of any kind of serious shunt, the rule of serial continuity takes place. And so ideally in a patient without any shunt issues, the RV and the LV stroke volume should be virtually identical, following the laws of continuity. In terms of anatomy, as you can see, it's not as straightforward as compared with the left ventricle. In fact, it's a bit more complicated of a structure. On some views on short axis, you can see it looks triangular in appearance, especially on the short axis. On the long axis, whereas on the short axis views, you get more of a crescentic appearance. So it's not the most straightforward geometry that we're used to when we look at cardiac anatomy. But roughly speaking, when we talk about the right ventricle, we tend to describe it in terms of three different separate structures. There's the inlet involving the tricuspid, the apical region, and then the more outlet regions. And there are actually three different separator bands that moderator bands that go along with this. So septomarginal, kind of parietal layer out near the infundibulum, and then there's a separate moderator band section as well. In terms of its muscular arrangement, it's actually a bit more complex than the left ventricle, whereas the left ventricle kind of rotates so that it's anisotropic throughout the layers. The right ventricle actually is mostly circular in the mid layer, more oblique on the outer layer, and more longitudinal in the inner layer. So it does rotate, but as well, similar to left ventricle, as you go from endocardium to epicardial layer. But the more dominant forces tend to be more horizontal, circular, if you will, in appearance. It is contiguous with the left ventricle in the septum, the free wall. But if you look at enough of this anatomy, especially when we do our measurements, you'll notice that there's actually a bit of RV-LV separation in terms of the septal layer. So those are things to keep in mind. Okay. It's just rehashing what I just described before, the fact that you can roughly just separate it into an inlet, trabecular septum, apical region, and then the infundibular region, inflow and outflow, and apical region as well. Okay. The issue, though, with the right ventricle, like I said, is it's not the most clear-cut geometric shape. So unlike the left ventricle, which gives kind of a hemi-ellipsoid appearance and has clear circular parameters, the right ventricle is a bit more challenging to try to quantify more objectively. Okay. The right ventricle is also described as kind of the second ventricle, the orphan ventricle, so to speak. So in this day and age, more and more people are paying more attention to it. But nowadays, thankfully, it's getting the attention it deserves. But back in the day, it was fairly well neglected. These are shown here as a table indicating the difference between the RV and LV based on different parameters. And as you can see, there's not only the shape, but the myocardial mass is less. The thickness is much less. In fact, anything more than 5 millimeters in terms of wall thickness is considered hypertrophied, unlike the LV, which has to go above 1 centimeters or in thickness or more. It has a much lower vascular resistance and lower pressures. And but unlike the LV, it has greater resistance to ischemia. So if there is a lack of oxygen supply, it's a little more resilient. Okay. Sometimes when we're in the congenital world, and this is an area that our colleagues Dr. Duarte and Dr. Lin are very much in tune with. Trying to distinguish the right ventricle from the left ventricle is very important, and this actually comes up in a lot of cardiac imaging boards, especially echo boards and congenital heart board exams as well. But things to notice about the RV is that the atrioventricular valve, the tricuspid valve, tends to be more apically displaced, so much so that if it exceeds the 8 millimeters per meter squared displacement versus the anterior septal insertion of the mitral leaflet, then that's considered potentially diagnostics of Epstein's. Like I mentioned before, there's a moderator band, and yes, there's a moderator band in the RV. There's no moderator band in the LV. The RV also has a lot more papillary muscles, and it's not consistent from patient to patient. And for that reason, for reproducibility purposes, we tend not to try to relegate the papillary muscles to outside the RV cavity. It becomes a lot more complicated to reproduce. I mentioned a trileaflet tricuspid valve, appropriately named, and coarse trabeculations, of course. Okay. And unlike the LV, which has a clear-cut, in the absence of bundle branch block, a clear-cut contraction where everything comes together in a uniform fashion with an electrical signal, RV mechanics is a bit more complicated. It actually has more of a peristaltic motion, where the inlet and apex contracts first, then followed by the outlet infundibulum about 25 to 50 milliseconds later. This becomes more exaggerated when there's a conduction delay. Again, this shows that the RV is less more of a pressure media phenomenon. It's more of a kind of mass flow related phenomenon in terms of its function. So much so that you actually have some phenomena that show up in the cath tracings of the RV and PA that don't show up with the LV and aorta. There's actually a hangout period where the RV pressure drops. The PA pressure is still elevated, but the pulmonic valve hasn't closed. So you actually have this hangout phenomenon that can actually persist a bit before the pulmonic valve actually closes. Again, emphasizing the fact that this is more a mass flow mass related principle guiding the circulation in the right ventricle as opposed to the left ventricle. That's the principle that I want to emphasize about the right ventricle in terms of hemodynamics. Calculating the pulmonary vascular resistance is pretty straightforward. It's just simply taking pressure over cardiac output. In this case, you would do the mean pulmonary pressures, and unlike the pulmonary capillary wedge, you would use the RA pressure as a difference. Okay. And the last thing I want to point out about the right ventricle is that if there's any pathophysiology involved, where the pulmonary pressures go up, the right ventricle, like I said, is more flow mediated. It is less forgiving if the pulmonary pressures go up. Shown here is the stroke volume that the two different ventricles can put out. Left ventricle, as you can see, as we raise the systolic blood pressure that the left ventricle has to push against and put out against in the systemic vascular resistance. The right ventricle, when you increase it just only a few millimeters of mercury, there's a drastic drop in stroke volume as well. So again, the RV is much less forgiving in terms of higher pulmonary pressures. So whenever pulmonary hypertension develops in these patients, it becomes a big deal because that can impact the overall circuit flow. Okay. So then the question becomes, why do cardiac CMR? Because if you have a different imaging modality, if you're going to pick a different imaging modality to image a patient as opposed to echo or CT or any other modality, there must be a reason why that imaging modality is used, why there's certain advantages with that modality over others. Back in the just only a decade ago, the original guidelines for assessing the right heart actually argued against using echo for RVEF. That has changed now that 3D techniques are evolving with echo, and I haven't seen any new updates on this, but now 3D echo has been considered comparable to CMR and CT techniques for assessing the right ventricle. Although that's an area that's continuing to evolve, and if a center is going to do it, they have to be experienced with it. But when it comes to CMR actually does have some advantages. It has a very large field of view, so you get to see not only of course, the heart, which is what we're all interested in, but you also get the other structures, surrounding structures of interest. So you get additional information, extra cardiac findings for free. You can set whatever imaging plane you want on the patient, so you're not limited to just to whatever acoustic windows you can achieve, and you can actually get a pretty decent image resolution, and not just a spatial resolution, but also temporal resolution in most patients. There's also the advantage with CMR that you can actually do further tissue characterization, and I'll cover that towards the end. And then of course, the big thing about CMR is that its ability to do volumes across a high temporal resolution compared to other modalities. But accurate spatial volumes, along with a decent temporal resolution as well. So I did mention that it's highly accurate, and this has been proven in using cadaveric and real-life studies. So there have been multiple studies where not only in cadaveric hearts, but also in patients who undergo hemodynamic studies in the cath lab. It has been shown that the tomographic technique, the Simpson's using Simpson's rule of stacks of discs, that we can get very accurate volumes, and so much so that there's very low variability so that you have low intra-observer variation, low inter-observer variation, and very low inter-study variation in patients when you bring them back. This becomes important because when you do want to serially assess these patients or have different people read the study on different patients, if you have too much variation, that introduces a lot of noise into assessment of the right ventricle and chamber quantification, and that's something we want to reduce overall in the imaging world. Okay. When it comes, and then this is just showing the evolution through the different time periods. Shown here is literature, a table from an article in CIRC Cardiovascular Imaging, showing that over time, the reproducibility of the RV and LV did continue to improve over time, and this was true of the LV and RV. But this is what established the fact that ventricular volume measurements were reproducible. Okay. Now, what about what's considered normal versus what's not? And there's in the world of CMR, we use a lot of data from King's College. Dr. Macera and her group recruited a set of about 100 volunteers and binned them into different deciles of age, and came up with these different figures for endoscopic volume and systolic volume, stroke volume, EF, and mass. And this is shown here, showing differences, showing the overall characteristic cohort, division by males versus females, and then also a breakdown by decile of age. And true to form, just like the LV, the RV, as we get older, tends to get smaller in size, and the EF also tends to get larger as a result of the shrinking denominator as well. Okay. But this is the reference that we use. There's been some advances in that, but all the data still boil down to accommodating the age and gender of these patients when it comes to determining whether or not they have a dilated ventricle or decreased systolic volume, decreased EF, etc. Okay. So now that I answered what the RV does and and why cardiac MRI, how do we do it? So we start off with conventional anatomic views. So shown here is a nice axial view, and we do an oblique sagittal plane centered on the left ventricle. This gives us a pseudo two chamber. From that, pseudo two chamber and and then from that, we make adjustments of an oblique axial plane, and this gives us pseudo four chamber. From that, then we center everything on the left ventricle with a stack of cines, and then we get these beautiful stacks going through the base to the apex of the heart that then allows us to do our quantifications. For additional views, all of us may have seen this in Dr. Feigenbaum's echo text before, but this is showing a real cine example where we then do additional cuts to try to get the other chamber views. And I do bring this up also because just not long ago we had professor rounds, and I remember a fellow being asked to assess a four-chamber view of the heart, and he commented the RV looks a little bit generous. The problem with this is that you can see we alter our plane to optimize getting the largest RV. So be careful when you assess the chamber sizes, because you want to know how your technique was done and what scan planes were chosen. Case in point, I'll bring it up a little later, but in echo, if you look at your echo protocol, there is such thing as an RV focus view, which is different from a standard LV four-chamber view, because the RV in that case is focused, is altered a bit more to give cuts that are a little bit similar to what I'm showing here. But I want to rule out the misconception that just because the RV looks a little more generous, throw away that idea. Know what you're actually scanning before you make that assumption. Know how your imaging setup, your imaging acquisition was set up before making that kind of comment. Okay. When it comes to the RV, we actually are able to acquire a couple other views. We can actually orient planes that are I was taught to kind of snowman view in the high basal short axis, and this actually gives us the RV three-chamber view. This is CMR is one of the few modalities that can actually give you the inflow-outflow view very nicely. So you can see the tricuspid and pulmonary valves and the anterior and inferior parts of the RV free wall pretty nicely. We can actually get a separate, a slightly oblique cut and end up with an RV two-chamber view as well. Okay. And then for added measure, we do a perpendicular plane view through the RVOT to get the RVOT, a separate RVOT view, just for good measure. Okay. But this is from Dr. Rutsky's paper and Jace talking about echo acquisition of RV. And you can see that depending on how you rotate the probe, you can actually shift how the RV looks. This is very true in the CMR world and true in the echo world. Depending on what you're optimizing your views for, you can make the views look very, very different. Okay. Now, of course, we can also do visual assessments, and shown here if this will play. Okay, the view here is not playing, but that's okay. What this top view shows here is what a normal RV would look like when it's contracting, and you'll see that there's a contraction of the lateral wall. It shrinks down. You'll also see the tricuspid descent So those are different things to pay attention to visually, and you also see the lateral wall and the short axis come in. The danger with commenting on RV function of the on the short axis, though, is that because everything is translating translating through the plane as well, one can get confused and get fooled into thinking that parts of the wall are not moving because different parts of the RV actually coming into plane in the different views. If this played, this is not playing either, but if this played, this would also would show that the RV is not actually doing any of the stuff I said. The lateral wall would not be contracting as vigorously. The tricuspid annulus would not be descending as well. You would see the lateral wall on the short axis not as vigorous a view. And then, but one thing that can still be appreciated on CMR is the fact that you can see whether or not the RV is severely dilated. Shown here, there's no doubt in this case that there's very much apical dominance of the RV. Its short axis dimensions are much much greater than the LV. In fact, the LV looks kind of smallish and compressed in its appearance. Even have a septal flattening in this case. Which is consistent with the RV overload picture in this case as well. Shown here is a case of RV hypertrophy, and then also a case of both septal systolic and diastolic flattening. And this is all consistent with a patient with pulmonary hypertension who has pressure. You can see that there's so much pressure in the right ventricle, it's actually squeezing against the left ventricle in systole, as well as a diastolic volume overload in this case. Okay. And then one other thing I want to point out. Okay, and this is not playing either, but that's okay. When we give contrast to these patients, gadolinium contrast, we actually do an MR angiogram looking at the thoracic aorta. But when we do that, it actually has to pass through the SVC into the RA. And if the RA has elevated pressures or there's significant tricuspid regurgitation, you'll actually get contrast reflux into the hepatic vein. So this is the equivalent of the Doppler hepatic venous reversal that's seen in a spectral Doppler echo. So we actually integrate this information as well when we're assessing the right side of the heart for significant TR or elevated RA pressures. So something to keep in mind when you're looking at an angiogram. Now, going on into how we then post-process the ventricle and quantify things, I mentioned before we make no geometric assumptions and we use the stack of discs Simpson method. And shown here, we make no geometric assumptions about the shape of the RV. We get tomographic slices through, and we trace everything from base to apex, and we can end up with an end-to-diastolic volume. Repeat that in systole, and then you can quantify your ejection fraction from that as well. Okay. And then, of course, every slice is whatever thickness you set it to. And in this case, we usually do increments of about 10 millimeters. So about 1 centimeter gaps, I should say gaps, but 1 centimeter between the different slices that we acquire of the ventricle. Okay. We actually have one other method that for CMR quantification that we use, and that's the phase contrast method. So you can think of it as kind of the equivalent of a pulsoid Doppler. Although unlike echo, where the beams aligned parallel to the flow, we orient ourselves perpendicular flow. And what we can do is then acquire a phase contrast images where the intensity of the pixel, be it black or white, depending on whatever direction you encode, then corresponds to velocity. We sum up all the velocities, kind of get a mean velocity for that area, and velocity times area gives you flow, and we can then get a flow curve and get stroke volume through the pulmonary artery, through the pulmonic valve. Okay. Now, a question has come up in the past before. Well, we do it short axis here. Some centers get axial stacks and actually do axial RV. Is there actually a difference? And turns out, not really. The RV and LV provide very similar information, and it's been shown that when you compare the two, they're pretty much on par. So is there any advantage of doing one or the other? Well, the answer is actually yes. There is one particular pathology that does lend itself better to the axial method of RV quantification over the short axis cardiac stack, and that's an Epstein's anomaly. The reason being is because you have atrialization of the right ventricle, usually a very long redundant leaflet, leaflet, and a very short septal leaflet. Then the right ventricle is not as well appreciated on the short axis because the tricuspid valve is not as well appreciated on the short axis, whereas it's better appreciated on the axial stacks. And so you can actually then adjust your concentrations to get the true morphologic RV in the Epstein's case to accommodate that. So we do try to remind the CMR techs whenever we have an Epstein case show up to then try to get axial synase covering the entire right ventricle, so that then we can provide a more accurate true RV quantification in that case. Otherwise, the two are roughly equivalent, and some centers will do one over the other. Okay, and this is just showing how the axial stacks that I showed versus short axis stacks compare with phase contrast imaging of the PA stroke volume. Okay. This is just harkening back to, in fact, when it comes to the right ventricle, one of our favorite customers is the congenital heart folks. And congenital heart disease, since many of the things that get affected in congenital heart disease affect the right ventricle. It's actually recommended not only for Epstein's, but many different congenital heart diseases for assessing the RV and RV function. So does it clinically matter? And that's always a good question. Dr. Quinones is a so what kind of question. And for that, I hope to take you through some different show you some prognostic information, basic prognostic information, and take you through some different cases, showing some use case scenarios. So RV function does matter. In fact, so much so that I know Dr. Naga last week talked about how it's important in terms of patients' cardiac function and also their prognosis. Shown here is the data from Dr. Vocal and others back in a publication in Circulation back in 2006, and he showed that if you're whether or not you have normal or high PA, preserved RVF or low RVF, in all those cases, their survival was overall roughly pretty similar on the Kaplan-Meier survival curve, groups 1 through 3. But the moment your RVEF goes for patients with pulmonary hypertension, the prognosis becomes much more grim. You can see there's a more rapid drop-off in survival over time. So yes, RV function, RVEF does matter, and so knowing what the RV function is in patients with high pulmonary pressures for whatever reasons, be it left-sided heart failure, primary pulmonary hypertension, etc., then the RV function becomes very important prognostically. So let's move into the different cases, and since I'm on Zoom, I hope I have some fellows around because I'm going to be picking on you guys. But for the fellows, we have a patient here admitted for chest pain, and shown here is a 4-chamber view, as well as a short axis view, and an LGE image. Can anyone unmute and comment on what they see?
So there is, on the LGE on the far right, basically there's a transmural infarct, looks like, in the inferior wall that I can see. Also, when you look at the wall motions, the inferior, the mid-inferior, because we see the pap muscle of the mid-inferior does not move as well as the other walls. Looks at least severely hypokinetic from this picture. I mean, I need another picture.
Yes, yes. And how about the LGE?
I'm sorry, and then the LGE, the RV has actually, LGE, I just started looking at it again. The RV has LGE all the way as well. So the inferior, and then the lateral wall also, the bottom lateral, I should say, on the image. And then the RV looks bigger than the LV, at least on the 4-chamber, with some decreased function. The LV the function looks okay. Thickened mitral valve, at least. And then tricuspid, there's TR for sure, and the RA is big.
So, George, what do you think happened to this patient?
I mean, it looks like, at least given the involvement of the mid-inferior and then the RV, I mean, it looks like an infarct basically on the RCA.
Yes. So you were astute. You pointed out that there's akinesis of the inferior RV wall. There's LGE in the same region. There's also inferior septal infarct in the LV. And so this patient came in with an RCA infarct and RCA STEMI. And when he had the CMR done, this highlighted nicely that his RV had gone down because of an associated RV infarct. But great job. And this is just showing more of the same.
Eric, did George also comment on the papillary muscles?
No, he did not. But yes, you are correct, Dr. Shah. There's actually you can actually see the papillaries, the posterior medial papillaries on the cine, but then they kind of disappear on the LG. So that astute as always, Dr. Shah, that's indicative of papillary scarring, papillary involvement. So papillary infarct for sure. Okay. But these are different images just showing roughly the same in more different views, showing more of the RV in the 3-chamber and the 2-chamber view. And you can see again that the inferior wall is completely out, whereas the anterior RV is preserved. So this is a case where the patient didn't get so lucky. Remember, I said much earlier that the RV is usually spared in terms of ischemia. In this case, this patient was not with the infarct. And so the RV had gone out. So when RV infarct does occur, it's a pretty serious issue because we've all got taught in medical school that this presents with a triad: hypotension, elevated jugular veins, clear lung fields. These are patients that you want to be very, very careful of giving beta blockers and nitroglycerin, because you may catastrophically lower their blood pressure, in fact, cause them to go into shock. In fact, these patients are a little more volume dependent. We've learned nowadays not to go overboard with volume resuscitating patients, but you still want to keep them a little on the wetter side because they're definitely a lot more preload dependent with their RV out of non-functional out of the picture. Unfortunately, it does have it does become hemodynamically significant in about 10% of patients, but it's actually more prevalent than we like. The CMR world has kind of elucidated that. So when patients come in with RCA disease, RCA infarcts, I make it a point to look out for concurrent RV infarct, because that's also important. It's actually so important that it's so important that it impacts survival. And this article back in 2001, where RVMI was demonstrated, shows that it had a strong contributor to mortality in these patients. You can see all the different beta coefficients in this model predicting survival in the patients. RVMI by far was a very large component of survival in these patients. Okay. And then this is just a meta-analysis bringing home the point that when RV infarct is present versus absent, that mortality goes up, cardiogenic shock goes up, arrhythmias and conduction blocks go up. So again, very important to note when you're doing CMR and you pick this up. Moving on, this is a patient who has a history of PVCs. Actually, some of you may know her. She works with us, but she had PVCs a lot. Some unexplained dizziness every now and then. And one of our former CMR fellows finally got to capture images on her when her heart was cooperative. For the fellows, CMR fellows, Amr, are you on?
Yes. So
What do you see?
So here the RV looks dilated compared
Yes.
to the LV, and also we could appreciate a wall motion abnormality like at the base compared to the apex. So when seeing that, it comes to mind the ARVC.
Yes. So you're absolutely right. The RV is a bit dilated. The RVEF, it actually looks not so hot. In fact, if you look at the lateral tricuspid annulus, it's not as vigorous an excursion. Hopefully, the people in the echo side are far more cognizant of looking at TAPSE and using that to kind of gauge RV function. But the visual TAPSE, so to speak, in this case, is not so hot. And then, Amr, what do you think? What do you think of the anterior RV?
So the anterior RV is looks also like does have a hypokinesia actually.
What about this? You see my mouse?
Is that a dyskinetic portion segment of the RV?
Exactly. Yes, dyskinesia. Remember, we had a discussion the other day about hypokinesis, akinesis, and dyskinesia.
Right.
You clearly see when the RV is contracted in systole, this portion actually gets bigger compared to diastole.
Correct.
So this is true RV dyskinesia.
Perfect. Thanks.
I think it's more, it's actually aneurysm, because if you look in diastole, there's a displacement of the shape. There's an outpouching in diastole as well, right?
Yes, yes, yes. But this has all the hallmarks, as Amr pointed out, of ARVC, arrhythmogenic ventricular cardiomyopathy. So much so that this patient went on to get a defibrillator and get the rest of the family screened. Okay, but in terms of the diagnostic criteria for ARVC, remember it's a clinical diagnosis. It's not simply an imaging diagnosis. CMR just happens to be one component of it, and shown here is the 2010 task force criteria for classifying major and minor criteria by CMR. So just to reiterate, for CMR, you need first of all, you need regional wall motion abnormalities, either akinesia, dyskinesia of the RV somewhere, or dyssynchrony. That's a must. You can see that both for major and minor. That's the first bullet point, and one of the following: either the RV EDV is dilated, different criteria for male or female, greater than 100, 100 for female, greater than 110 for indexed RV EDV, or an ejection fraction less than 40%. Minor criteria are less strict, and the next step down, if you will. But keep in mind, this is only one criteria. You have to look at other criteria like a clinical history, ECG findings. If a biopsy is done, fibrofatty infiltrate is considered one of them. Used to be a criteria for CMR, the fibrofatty criteria, but it's been found that we overcall that a lot, and you can actually get this in patients with lipomatosis, with excessive fat in the mediastinum and obese individuals. So the MRI criteria have completely removed that, and we no longer call fibrofatty infiltrate. Although if we do see it, we'll comment on it, but it's not considered one of the necessary criteria for diagnosing ARVC by MRI. It's not so. Even though we do have this criteria, it's while it's a fairly specific, it's not sensitive. Obviously, patients will have any number of different pathologies, RV infarct, pulmonary hypertension, who knows what else that can cause these changes. So just because we have some of these criteria, especially just the simple volume and function, that itself is not sensitive for ARVC. So please keep that in mind. Shown here are the sensitivity and specificities for picking up ARVC and confirmed ARVC patients. Now moving on, this is another common indication for sending patients to CMR. So this is a 30-year-old former fellow of ours who decided to volunteer for research. And any of the fellows want to comment on what they see, what they think?
And functions, both functions are okay. Left and right RV, both valves are a little bit thickened. It looks like the chambers are dilated. It's hard to say, I mean, without really measuring, but it looks like at least the RA and the LA are dilated. Maybe also I would say the LV and the RV. I mean, to be honest, it looks like an athlete's heart, just if I had to pick one thing now. And then pulmonic is okay, tricuspid is okay, the RV is fine, no criteria for ARVD like we just discussed. And I think pulmonary veins, at least we see two.
Yeah, so this particular volunteer was like you, George. He works out a lot, actually does a lot of running, cardio, and absolutely his heart rates were in the 50s. The chambers did come out dilated, but everything came out normal function, no issues whatsoever. But this comes out again and again as to whether or not we're dealing with someone with a pathologic enlargement of the different chamber sizes, right ventricle and RA included. And so these patients show up in our CMR lab, and then we do go through all this, look at their clinical history, and have to comment on whether or not we're deciding if we're dealing with an athlete's heart or not. And you're absolutely right. Shown here is some data by Lagersh, et cetera, who et al. Who did a comparison between non-athlete and endurance athletes' hearts, and sure enough, actually found that that there was an increased RV to LV ratio, RV to LV ratio, and these patients. For the EDV, not so much a difference. And systolic volume, there was a difference. So much so that the RV-LV ratio was more elevated than systolic. But the EF was actually kind of reversed ratio-wise. But the mass was relatively the same. This is comparing athletes versus non-athletes. But the RV actually is one of the first things to start remodeling and changing in athletes. And this does get into the discussion of not every athlete's the same. Some do more resistance exercises or weightlifting, etc., which is a bit different from those who do more aerobic exercises like marathon running, etc. The way the heart adapts is very different between the two between the different types of exercises that are done, depending on its effects on the heart. But the RV for sure is one of the things that first begin enlarging and having all these differences as well. Okay. In fact, Mesa actually went through and looked at the different parameters based on quintiles of exercise activity, and again confirmed that the more athletic you are, the higher quintile of exercise you are, even adjusted for other different things. The larger EDV, the larger your stroke volume, but no difference in the ejection fraction overall. But yes, well-developed athletes do have larger right ventricles, and is the bottom line. Okay. Often the two get confused, though. A lot of times we get patients who come in with unexplained dizziness and passing out, and so then the question becomes ARVC or athlete's heart. And so looking at the different criteria, you'll see that athletes tend to have much larger ventricles, but their EF is fairly decently well preserved. Otherwise, their mass. Let's see. Yeah, their overall mass tends to be LV mass tends to be preserved. They didn't quantify RV mass in here, forgive me, but they tended to not have as dilated ventricles compared in terms of ratio versus the ARVC patients. And ARVC patients tended to have more wall motion abnormalities, LGE, etc. And hence why I bring up the fact again that